Hello, welcome to the kidney lecture, chapter 27. So just as a little basic review, these are the kidneys and they're located in the flank area. We've got the left kidney and the right kidney. So they are in the stomach area, but they're behind the stomach and they're behind the GI tract. It's called retroperitoneal, behind the peritoneal area, and it's protected here by these ribs. This blue line right here, look, this angle is called the costovertebral angle. And it's actually, we can palpate the kidneys in this space right here, in this angle underneath the ribs, the 12th rib right here. Sometimes when somebody's having flank pain or pain in this area, we call it flank pain, F-L-A-N-K. The bean-shaped kidneys are retroperitoneal or posterior to the abdominal contents. They are well protected by the posterior ribs and musculature. The 12th rib forms an angle with the vertebral column, and hence the name costovertebral angle. Roles of the kidneys is to filter, reabsorb, and excrete. So acute kidney injury used to be called acute renal failure, ARF, but the new terminology is AKI, acute kidney injury. The sudden decrease in kidney function occurring over hours for some people, or this could take days. So it can be very quick depending on the cause, or it could be a little bit more long-term depending on the cause. May be reversible with early identification and treatment. That's why we want to pick up on this, which we're going to talk about the symptoms. We want to pick up on this pretty quickly because it is reversible up to a certain point. And after a certain point, many people lose their kidneys because interventions weren't initiated in a timely response. Up to 5 to 20% of hospitalized patients will develop this. Look at this. 1 out of almost every 3 patients in the ICU gets some type of acute kidney injury. So this is something we deal with in the ICU frequently. Common in adults and elderly. Different than chronic kidney disease. So this acute kidney injury is acute. Chronic kidney disease, which is chronic. Chronic kidney disease, which is progressive and irreversible. When they get to chronic kidney disease, it's irreversible. The destruction has occurred. There's no going back. Irreversible destruction of the kidneys and often progresses into end-stage renal disease, the last stage, stage 5, nothing we can do about it other than dialyze a patient within months or years. So this is an important slide, so pay attention to this as far as what are causes of renal failure. And they're divided into 3 different categories. They're either pre-renal causes, intra-renal causes, or post-renal causes. It's important that you can delineate. So let's start with number 1, pre-renal. You can see where the number 1 is right here. The heart's up here, the left ventricle pumps, the blood comes out of the left ventricle into the aorta. It comes down and it has to make 2 sharp right angles to get into the renal arteries to perfuse these kidneys and bring them oxygenated blood. When patients have severe drop in blood pressure, shock, or any type of interruption of blood flow to the kidneys, and the blood just can't quite get in here, anything that could cause a decreased cardiac output, heart failure, hypovolemia, when the blood comes out of the left ventricle and it comes down the aorta, there's a small amount, or it's too small of an amount, and it doesn't have the ability to turn in to these renal arteries. And the kidneys are the very first organ to take a beating when we have a severe drop in blood pressure or shock or dehydration or heart failure. They really take a beating because they can't get oxygenated blood. So anything that could cause renal failure, that by that mechanism, we call it pre-renal failure. Okay, pre-renal. This is something that's happening before the kidneys. The blood hasn't even gotten to the kidneys yet. Generally, it's a loss of anything that could cause a loss of perfusion to those kidneys. The second one is intrarenal, intra meaning inside the kidneys. Actual kidney damage, a punch to the kidneys, not something that happens before. Direct damage to the kidneys by inflammation, toxins, drugs, infection, or a reduced blood supply. So after somebody has a reduced blood supply and then the kidneys become ischemic, okay, then that would be more like that's kidney damage that's occurring. That would be intrarenal. So anything that could cause inflammation, toxins, drugs are very common reasons why somebody has intrarenal failure. We give them antibiotics that can cause it. Heavy metals, different types of substances in the body that just circulates in the bloodstream, travels to the kidney, and it's just too harsh on the kidney, and it causes intrarenal failure. The third one, which is the least common one, is postrenal, which is caused by a sudden obstruction of urine flow due to an enlarged prostate, a kidney stone, a bladder tumor, or an injury. And you can see the three down here. Postrenal, it's happening beyond the kidney, post kidney, after the kidney. So right here, it could be something that happens in the ureter. A stone gets stuck right here. An obstruction, a tumor is growing right here. Or it could happen here in the bladder. Common is this right here, number 3, happening in the prostate in men. They get benign prostate hypertrophy, and this prostate gets bigger and bigger and bigger and pushes on that urethra. And as it does that, it doesn't allow the the urine to come out through the urethra. So an enlarged prostate, a kidney stone could get stuck here in the urethra, could get stuck here in the ureter. And hence there's a blockage that occurs. Either a blockage here, a blockage here, or a blockage here. And then the urine starts accumulating and getting stuck in the kidneys, and the kidney gets hydronephrosis, so it's just filling up with urine. It could happen to one side. So if there's say for example, a kidney stone right here, there would be nothing wrong with this kidney. It would be fine. And this person might just have hydronephrosis of one kidney. Or it can be something that occurs, a big tumor in the bladder or the prostate or a big stone in the urethra. And in that case, it would cause a bilateral hydronephrosis. Both the right and the left kidney are just filling up with urine, and it could put somebody in a post-renal failure. So those are important to understand, those 3 different causes and examples that go with that cause. Rhabdomyolysis is a syndrome characterized by excessive skeletal muscle breakdown. So that you should know the definition of that. When skeletal muscle is broken down, myoglobin is released, and myoglobin circulates in the blood, and it becomes very toxic to the kidneys. Well, we have skeletal muscle that breaks down. This is something that causes somebody's skeletal muscle to break down too rapidly. We're always having skeletal. You go to the gym and you lift weights, your skeletal muscle is breaking down. Just getting through the day. I mean, it's just part of skeletal muscle. The cells are going to break down and rebuild, and it releases this myoglobin. So this myoglobin is located in the striated muscle, and it's on here. It's a red color, and it helps the muscle store oxygen. So the myoglobin is important. Oxygen attaches to it, and we can keep oxygen stored in the muscle. It produces this red color right here, and then this is a little kind of a close-up picture of it. Right here, the muscle, the myoglobin in the muscle. And it produces a red color in the muscle, and then when it's released in the blood, it produces a dark color in the urine. And so this myoglobin gets excreted too much for various reasons, and it travels around in the bloodstream, and this myoglobin gets stuck in the kidneys, and it's a cause of some renal failure, intrarenal failure. It's actually causing damage intrarenally into there. And this can be manifested by what we call Coca-Cola urine, or this dark colored urine. It could be myoglobin in the urine. That's something that we do see. So what are some things that cause rhabdo? Crush injuries, somebody gets crushed by something, they're in a motor vehicle accident, their legs are crushed with something that fell on it. Severe burns will cause excessive skeletal muscle breakdown because of the burns on the muscle. Seizures can cause skeletal muscle breakdown, the tonic clonic activity. HMG-CoA reductase inhibitors, which you know as the statins, which are cholesterol lowering medication. That's really important to understand, because what happens is the statins work in the liver to prevent cholesterol from forming, and it keeps cholesterols down. But one of the side effects of it is it increases this muscle breakdown. So when somebody's taking a statin, we have to be concerned about a few things. One, we have to be concerned about their liver enzymes, because I just told you that's one of the side effects. And two, we have to be concerned about any type of sore muscles that they may have. Gosh, my calves are hurting me, my thighs are hurting me, any kind of it, because it increases that muscle breakdown, and it could put somebody into a rhabdo. So statins could put somebody into a rhabdo, and that's important to know about the statins. The lab is a creatinine phosphokinase, or a CPK, and sometimes it's just referred to as a CK, but those are the same things. And it gives us an indication of muscle breakdown of skeletal muscle. And when somebody has any of these things that are putting them into a rhabdo, their CPK will be very, very high. It increases because this is a measurement of skeletal muscle breakdown. So when this is increased, it indicates that there's some injury or stress to the muscle, among other things, but in this case, the muscle. Acute kidney injury risk factors. Well, we just talked about it. Just being in the hospital is a risk factor, especially in the ICU. The older we get, the more nephrons that have died, because that's part of aging. So age greater than 65. Race, being Black, there's a gene variant that's just more common in Blacks than in whites, and they are much more predisposed to having an acute kidney injury. They have a genetic risk factor. Chronic diseases, so peripheral arterial disease, diabetes, hypertension, and these three things right here all have something in common, and they all have vessel disease. Peripheral vascular disease, their vessels are garbage. Somebody who has diabetes, their vessels are terrible because of the too much sugar in the vessels, and it really beats up on the endothelium of the vessel, so they have terrible vascular disease. Hypertension is certainly something that can be caused by atherosclerosis and the lumen of the vessels getting smaller. We could also add here, that's certainly risk factors. Go ahead and put them to the side. Smoking is something that leads to hypertension. It leads to peripheral arterial disease. It leads to terrible vessel disease. A lot of people who have terrible vessel disease are either smokers or diabetics. Those are the two most common people. When you start seeing people who are getting bypasses in their arteries in their legs, and they have getting a limb amputated or something, they're just always a smoker or a diabetic patient because of that vascular disease. Another risk factor is sodium retaining states. Somebody has heart failure, or somebody has cirrhosis, and they're just retaining sodium, and they're retaining water, and they're not putting any urine out. So their kidney takes a beating as far as just this water, instead of going through the kidneys like it's supposed to, it just starts accumulating in the body. Exposure to nephrotoxins. So some nephrotoxins, number one being dye, which is really important to know. So the CAT scan, like when you get a CAT scan with contrast, that contrast dye is really harsh on the kidneys, and that could cause an intrarenal kidney failure. So anybody who gets a test and they have to get some contrast with it, when they come post-op, they're always getting an IV, and we're flushing fluids and wanting them to get increase fluid so we can flush the dye out of their body, most particularly their kidneys. There's certain groups of antibiotics that are just not nephro-friendly at all. They really beat up the kidneys. One example you may know, aminoglycosides, and we see these aminoglycosides actually being used in the ICU. And they're not at the top of the list to use, but sometimes when the other antibiotics don't work, we have to go to like a gentamicin or neomycin or something, and we know that it's just going to wreak havoc on the person's kidney, but it's the antibiotic that they need for their pneumonia or for their sepsis or something. So antibiotics, I only gave you one name, but there are other antibiotics that can be really tough on the kidneys. ACE inhibitors. Generally, the medication, the ACE inhibitors, which we've talked about, are pretty renal friendly. They're good for the kidneys. We call them renal protectors because what they do is they vasodilate the efferent artery, so the artery coming in here to the nephron, to the Bowman's capsule, and it dilates it, and which is super helpful. So it gets a lot of really good blood supply to it. But what happens is when somebody has certain circumstances, like for example, they have a low perfusion state. Maybe their cardiac output comes down for a reason. Their kidneys aren't getting a lot of fluid. The natural ability of the arteries in the kidneys are to constrict and kind of help out, just kind of help out to get that fluid kind of pumped through the kidney. And when somebody's on an ACE inhibitor, that obviously isn't going to happen. It kind of overrides that compensatory mechanism we have. So a couple things to know on the outside looking in as far as ACE inhibitors. When somebody's on an ACE inhibitor and their creatinine starts getting greater than 3, that's an indication that this ACE inhibitor is going to cause this person a lot more harm than good. Up until then, it's very healthy for the kidneys, but there's things that are just going to occur, like nephrotoxicity or whatever it is. And once the creatinine gets 3, we hold ACE inhibitors because they're only going to contribute to the renal disease. Also, if somebody's potassium is greater than 5, that's another reason to hold an ACE inhibitor. And remember, ACE inhibitors are interfering with the retention of aldosterone. So hence, these people hold on to potassium. So a creatinine greater than 3 or a potassium greater than 5 would warrant you to hold ACE inhibitors.